We are all over the world right now, and that's very exciting. It feels like it. My name is Andrew Hunt. I'm Senior Vice President at Project Control. I'm also current past president for the Founders Council, one of the sort of grassroots support organizations for Texas Biomed. Today, this is the Community is Essential discussion panel. And we believe that community is essential, so that's good. We're here having community. And so I've got a question for each of you. I'm joined by Commissioner Rebeca Clay-Flores from Bexar County, which is a county in Texas that San Antonio is in. We have, who do we have? Jessica Knudsen? Knudsen, thank you very much, Jessica. CEO and President of Clarity Child Guidance Center. And well, I'm going to have each of you speak a little bit about what this means. We have Dr. Alison Wiesenthal, who is, this is going to take a minute here, Chief, I don't say this right, Palliative Care Services, and also the Chair of the Department of Rehabilitation Medicine at the Center for Intrepid at Brooke Army Medical Center, our only and our largest level 4 trauma center in the country.
Level 1.
Level 1. Level 1.
Kind.
Very good. And I know you're going to set me straight here, all of you. And then we have Jennifer Potter. Dr. Potter, do you go by that? Just Jennifer Potter? Jennifer is Vice President of Research and Professor of Psychiatry and Behavioral Sciences at UT Health San Antonio. I'm just scratching the surface of what each of your interests are, each of your skills. We'll start at the end, and we're here to talk about strengthening social connection and compassion in the face of the pandemic. And there's a bunch of stuff we've experienced through COVID. We could tell some COVID stories if you like, but it's now what? So we now have kind of the pieces on the floor, Jennifer, in our communities. What are you seeing? What do you see in your role? What is your role? And talk for a few minutes, would you please?
Sure. Well, first, thank you so much for having us. It's really nice to be part of such an important panel. So my name is Jennifer Potter. I am the Vice President for Research at University of Texas Health Science Center, San Antonio, or UT Health SA. I think I'm also here because I'm a professor. You can call me Doctor. Jennifer Potter in the Department of Psychiatry and Behavioral Sciences. I think my filter right now is largely through my work in that capacity related to COVID, which is having lots of conversations and sharing concerns around the increase in substance use during COVID, alcohol as well as other drugs, at a time when we were working very hard in the United States, at least, to mitigate what we see as a really tragic public health failure, which is the lack of access to evidence-based treatment to address the overdose crisis that we're seeing in the United States today, largely as a result of opioids. So that's the filter that I come to with this conversation. We have a program called Be Well Texas. Okay. It's a statewide program designed to increase access to high-quality, compassionate, evidence-based treatment for all Texans, including those without the ability to pay. So a lot of our work is spent training providers, providing access to no-cost care and medicines, because there are very effective treatments for substance use disorder. The biggest challenge we have is access. And during the, you did want me to start talking, right?
Yeah,
I just started, so.
No, well,
Sure.
You mentioned evidence-based several times. What does that mean? I mean, evidence-based. So
sure.
That would assume, I guess, that there is care that is not based on evidence?
Well, that's a very good question. I appreciate that. So when I say evidence-based, I'm talking about treatments that have a preponderance of evidence that suggests that they work. So these are treatments that are rooted in science, using the best possible research designs to be able to say that that is the evidence base. Another way to say it that's probably a little more accessible is treatment that works. And when I'm looking at treatment that works, I'm talking about not just for a particular individual, but treatment that is the best opportunity for a positive outcome. And so that is evidence-based. The challenge that you bring up is that, unfortunately, and I think this is a problem we see in a lot of programs or areas where there's a behavioral component, is there are programs out there that just don't have the evidence to suggest that they work. In other words,
Got it.
they might be helpful. They might have worked for a particular individual or some individuals. But as a scientist, I want to maximize what we're delivering. Every dollar provided to healthcare is so precious, and to the programs that support people with mental health issues and substance use disorder issues. And so we have to really look at how we spend that in a way that's equitable, that works, and gives people the best possible chance for success. And that's what we're doing with Be Well Texas.
Excellent. So you're hitting on a cue here that I think is now becoming a lot more common of a topic is mental health. Mm-hmm. And so that's something I'm going to come back to you because I want to talk about alcohol in this setting and some of the use. But first, I would like to get a couple more of our panelists involved here. Alison, Dr. Wiesenthal, if you'd introduce yourself a little bit. There's a couple things you do that I'm going to ask questions about, but we'll see if you answer them in advance. Okay.
I'll see what I can do. Thank you, Andrew. I'm Alison Wiesenthal. I'm the chair of the Department of Rehabilitation at Brooke Army Medical Center, which, as Andrew said, is the only level 1 trauma center in the Department of Defense. So that means that when you have major traumas, that we are your go-to site. And so that also means that we need a lot of rehabilitation. So we also have the Center for the Intrepid, which is one of the most incredible public-private partnerships in the military, and it is how we rehabilitate our wounded warriors. So we get them either back into the fight if they're a soldier that wants to continue to serve in the military, or we get them back into the community as active as they can possibly be. And getting to be a part of that every day, especially when we're not at war, is really nice. And so, but again, it's like a lot of the things we're talking about today, where it's all about readiness. So, you just like Sal Weber was saying earlier, you can't build the ship. When you need the ship today, you have to have the ship built. So a lot of what we do in the military, especially at the Center for the Intrepid, is having that ship ready to go. So if we do have a mass casualty event moving forward, we will be able to handle those soldiers in whatever volume comes our way, and we will have the experience and the research capabilities to help those patients get moving again in whatever that looks like.
So Alison, would you tell us, there's two parts. What I'd like to do here is we'll set the table and then we'll eat. So I'd like to set the table with sort of the context of what each of you have been up to. What do you do? What are your interests in regarding particularly mental health? But with our adults, with our children, with our warriors, with our medical providers, with our community policies. Alison, you're involved with the South Texas Regional Advisory Council and resiliency something. Bringing resiliency. There's a name for it.
Such a good buzzword.
I don't have a PhD yet in full terminology. So you are credited with helping bring resiliency resources to medical providers in the area as part of your role. Would you describe that role? I think I know what resiliency means, but how did it apply in this case? Because this was a big part of sort of your body of work and a new context that you approach your work with. So tell us about that, would you, Alison?
Yes. So resiliency in a nutshell is, if I knock you down, how quickly will you get back up? So the goal with being a physician is that timing has to be pretty quick, because if somebody's not doing well in the next room, you still have to be able to walk into the room next door and be able to help that person feel better. So in terms of resiliency, COVID-19 was a big challenge for us because we didn't have all the answers. And as physicians, it's like one of our beloved things is being able to answer patients' questions and being able to help them. And so when you weren't able to tell people a solid answer, you weren't able to, say black and white, this is the right thing to do, this is the wrong thing to do, it was really compromising for our sense of self and our confidence in what we were able to provide. And so one of the things that I wanted to do when we got together, so STRAC has, it's the South Texas's way that we respond to emergencies. So this was the Pandemic Medical Work Group, so it included all the large health systems, and we all came together to say, how can we deliver care equitably? So during the pandemic, there was a big fear we wouldn't be able to have enough beds. So we were watching the news, we were seeing, patients on the street outside of hospitals, and we were like, oh my gosh, what if this is us? How are we going to manage it? And we got really lucky, and it wasn't us, but we were ready. So that working group was all about that. But I also, said, well, this is a really good space as well to get a resiliency group going, because doctors and nurses and all of the frontline providers, we were struggling because, again, you wake up in the morning and you don't think to yourself, well, I hope there's a mask for me today. But that was the moment.
Yeah.
Like, we really didn't even have the gear we needed to keep ourselves safe, and not even ourselves, because, when we take that oath, we say, we know we're walking into the fire. So we deal with sick people every day. We deal with communicable diseases every day. That wasn't new for us, but it was new for us to not know if we would have the equipment needed to keep ourselves safe. And more than that, to not bring that home to our families. So our resiliency was compromised greatly. And so it's all about how can we rebuild that, because you can't just say, like, oh, take a week vacation. Like, that'd be super great, but we couldn't. Like, not to be sad, but I haven't had a day off in a really long time. But it really is all about just keep going and keep helping as many people as you can. And so trying to find a way to, we called it kind of emotional PPE. How do you protect yourself emotionally to continue to do the work that you have to do while still, again, being able to walk into a room of somebody that hasn't done well and then walk out and be able to provide, just as high quality care to that person in the next door.
So I'm going to take that cue, because you just said a mantra that a whole lot of people said for their context during COVID, and it's led to much of the mental health crisis that we're experiencing today. And that is, I got to keep myself together. How am I going to keep myself together? I have this to do. And so Jessica Knudsen, closer? We'll get there before the hour's up. With your role, if you would explain to us what you do with the Clarity Children's Center, and I'm thinking of children, I'm thinking of the number of parents that said, I don't know how to do Zoom, and now I got to do it, and I got to do it for my kid, and I didn't even know my kids were learning at school or what they were learning, or and I have some jokes I'll share with that in a minute. But this was something that it sounded like everyone was experiencing, and it started to ladle on a new dimension of stress. So, if you would please.
I agree with everything that has been said so far. My name is Jessica Knudsen. I'm the president and CEO of Clarity Child Guidance Center. We are the only nonprofit in South Texas that is dedicated to the treatment of children's mental health, ages 3 to 17. And we do that in a wide variety of ways. We operate a 66-bed inpatient hospital, which is really for the kids that are in the most severe forms of crisis, a day hospital program for kids to come during the day, and then a whole host of outpatient services, both psychiatry, psychology, and therapy, with licensed practical counselors, LCSWs, partly in partnership with UT Health San Antonio in their residency program. And it's been hard. It's been a very difficult 2 years with the pandemic, and I echo everything Dr. Wiesenthal shared. What we call in the psychiatric field is secondary traumatization, that getting exposed to these things can be as damaging to the healthcare worker, potentially, and we definitely saw that on the behavioral health side as well. Behavioral health kept going during the pandemic. Our hospitals were still open. And I echo the fears about PPE. I mean, we really struggle with when do we mandate masking, because I know I don't have enough masks to mandate. Mm-hmm. So how can I tell staff you must wear them if we don't have enough in the closet? And so that was difficult for the staff. But I think the larger piece that I can speak to is the impact this has had on our children. And the topic today is that topic of socialization, and the best analogy I've heard, and this is not mine, and I wish I could remember whose it was to give them credit, is if you think about a kindergartner at the start of the pandemic. We picked them up out of kindergarten, and now we've plopped them back down into second grade, and we are shocked that they're not acting like a second grader. Of course they're not acting like a second grader, but we actually saw a spike in referrals because second graders weren't taking turns. They weren't following rules. They weren't sitting in their seat. again, of course, they're not following rules. They've been sitting in front of Zoom for the last year and a half. And so we've really had to do a lot of work with parents. And I think to your point of what can we do, I think it's also looking at our own expectations as parents, as teachers, as caregivers, about what is, and I hate the term, but the new normal. I mean, what can we expect from a second grader? And I think you can use that comparison to a kid in every age. Think about the social development from a freshman in high school to a junior in high school, and all the socialization and development of a peer group, and separation from parents, and all the stuff you're supposed to do as a teenager.
Eye rolls,
all of that. They didn't have the opportunity to do that. And so we're really trying to reteach them the things they've missed the last 18 months to 2 years. And that's really difficult. And we're also seeing some kids that haven't re-engaged yet. You know, they're still homeschooled. They haven't gone back because we're seeing admissions of kids that don't want to go back to school because they've got so accustomed to the way it has been. And that's a group we're concerned about. You know, if we miss this opportunity, if we miss this window, what does the next couple of years look like for them?
So what's your primary referrals? I would assume prior to COVID, anxiety, depression, certain types of acting out, self-harm. Are you seeing an adjustment to that? Not adjusting, to need to be inpatient is a significant thing. Are you seeing a change in patterns of behaviors?
We've seen about a 19% increase in kids that are admitted for suicidal thoughts, for thoughts of self-harm. So that's been the most significant thing. And then I would say secondarily, just anxiety in general. Has been the biggest increase we've seen.
Okay, very good. Well, I've got a bunch more questions for you as well, but we'll get to them. And if you have questions, my wonderful panelists, for each other, please dive in here because you're probably more interesting than me. So I'll bring into the fold now Commissioner Clay-Flores. So, Commissioner, for the benefit of our international audience, our global and intergalactic audience, I'm told we're broadcasting intergalactically. Explain the role of a county commissioner, the types of policies and decisions. Before you do that, though, I'm interrupting myself. This is not a good start, Commissioner. You're known also for the work you've done as a county commissioner in bringing attention and funding at the county level for children's mental health issues. It's something you were interested in before you came into the commissioner. So with those two pieces, what is a county commissioner? Sounds great. Now, what is it? And tell us some more.
Okay, so a county commissioner, obviously I'm an elected official. I represent a quarter of the population, so a little over 500,000 here in Bexar County. And basically we are the executive decision makers for the county. So we have to approve everyone's funding, from how much overtime pay at the jails to the courts, and also things of answering really angry constituents because of potholes or stray dogs in the far urban rural south side, which is part of the precinct that I represent. Personally, part of also what I do, just because of my background, is I consider myself a community advocate, a student activist. So it's about meeting with people like my colleagues here on the stage, decision makers, and also meeting with community members and trying to be that bridge to bring people together. I have to say it's a privilege to be on a panel with all women, the male moderator.
And little old me, okay.
Because oftentimes, ladies, I think you'll agree, it's often the other way around. I am Black and Mexican, so people think, we can just invite her and she diversifies everything, right? She's a woman, Latina, Black, but we need real diversity, not just in terms of gender, race, socioeconomic status, and also representations and powers and people who are able to make decisions. So oftentimes, my chief of staff and I talk about this a lot. Oftentimes before I wasn't often invited to the table. So I would be one of those people who would be carrying around my foldable chair, and I'm gonna come to the table anyway and make room because I have something to say. So now the difference is I have a title after my name. People put microphones in front of me. And I'm saying the same thing, doing the same work that I've been doing. But now there's some purse strings attached to that. So one of the things I'm really proud of is that my background's in education, and I've also done some work in public health. So one of the things I always talk about is, unfortunately, our jails are the #1 provider of mental health services in the state of Texas. So it's almost as if we wait for people to make a mistake, throw them in jail. Once they're in jail, we realize, oh wait, maybe they have a mental health issue.
Let me make sure I heard that right. Our jails are #1 provider of mental health services.
I would say this is common in
Okay.
America, but definitely in Texas, our
Okay.
jails are #1 provider of mental health services because of the stigma attached to mental health, and people either don't know what they're suffering from,
Yeah.
people just think they're bad, they're acting out in school, so then they get thrown in jail, and finally they get some kind of help at the expense of taxpayer dollars, of course.
Much more expensive.
As an educator, now that when I came into office, one of the things I had been preaching about previously is that we need to support and partner with schools and social service agencies to put more money for counselors and social workers in our schools. So Jessica here, one of my colleagues, Clarity, and I believe it's 5 others, so a total of 6 nonprofits here locally, have something called the Mobile Mental Wellness Unit, where they work together to provide counselors and social workers in schools. So one of the first things we did with our federal funding is I advocated to push for $4.75 million so that we can put more social workers and counselors in our schools, so we can start to attack these issues at an earlier age.
Yes. What does that look like? So they got the money, so and it's mobile. Does that mean that it's kind of like a food truck or like a blood drive van where you can go and you have some counseling?
Do you want to speak more to that?
Give us a picture of that, because what we're finding in our other discussions is that it's this local innovation that is making the biggest difference because it's nimble. And so I want our audience around the world to hear, what is this? What does it look like? Maybe we could do this. We've got food trucks.
So the really great thing about this collaborative is it was born from the students.
Okay.
It really, it launched in South San ISD, and it was students that mobilized, went to a school board meeting and basically said, if you're not addressing our mental health needs, how can we learn? If we're not taking care of our basic health, because mental health is health. There's not a delineation. And so that was really the impetus to it, and the organizations got together. South San has given us dedicated space. So we have a space called the Care Zone, where they've carved out, it was an empty wing of one of their elementary schools, and we have dedicated office space for each of the organizations. Wow. So our counselors go on site. Okay. And the other really great thing about that program is it's definitely there for kids, and that's one of the mission-driven points, but it's also there for teachers, it's also there for parents. Okay. So anyone in that community that is in need of behavioral health services, one of those partner agencies can meet that need. Good. And there's a version of the Care Zone basically at the other districts where we work. So no van.
Okay. That's less creepy. So that's good. Okay. Yeah. So, Commissioner, are you seeing feedback? Go ahead, make a point.
So I just want to explain that a little further. So why it's mobile is because if you have somebody who lives on, for example, my precinct in the far rural part of town, if you are a single parent, an hourly worker, you need counseling, a child recognizes that's a big burden on the parent because the parent has to take the time off, has to drive across town because most of the health providers on the north side. So if you don't have a vehicle, we didn't grow up with a car, and then if you have a vehicle, you have to put money in it, gas, and of course gas prices are really expensive. You have to take time off of work, so you're not getting your full pay. So the whole point of this is that we shouldn't put a burden on our students to have to drive across town to get the services they need. Yeah. So it's mobile because it's in the school, it's in the neighborhood. And it's not just for the students, because a lot of times children are suffering from childhood trauma because of their family environment. So it's also a place to do family counseling as well. So that's why it was so important to push so much money into this, because we talk a lot about, I've toured the center, and when you go and you recognize that there are children as young as 4, 5, 6, 7, 8, 9, 10. Think about a 4-year-old that you know, or your own child if you have children, or a 10-year-old, and what was so traumatic in that child's life that a weekly session with the counselor wasn't good enough. They had to take them out of their home to have 24/7 care because they were either violent towards themselves or to someone else, including sexual violence. Yes. So we talk about oh my goodness, children, but then we don't want to put money in it. And so we really need to practice what we preach, and we know that in America, that comes with attaching dollar signs to it.
So what are you seeing or receiving feedback yet? This has been underway for a year, 2 years, would you say? And are you getting feedback from, let's say, school administrators, teachers? We're seeing some improvements here.
That program has been in existence about 2.5 years.
Right on time?
Fully functioning. Yeah, we kind of started right pre-pandemic. I think some of the feedback is in volume of referrals. We tripled referrals the start of this school year. I think with the start of in-person school and then coming back into that environment, there was just an overwhelming need. The feedback from the families and the school administration is just overwhelming. The difference that it makes, to the commissioner's point, to have it in the neighborhood, accessible, and it also normalizes it. Unfortunately, there's still such the stigma related to behavioral health. It's still, so many people still see it as, oh, it's a weakness or something people should just be able to deal with.
Yeah.
The fact that it's there in the school, it's as normal as if you're going to your wellness checkup.
So I'm going to take that, if I could, and then I'm thinking of a couple of things. One's access, one's the stigma. Are you seeing a difference? This would be across the board in the resiliency. Are you looking for help? Are you finding a difference in men versus women seeking help, boys versus girls? And then, well, let's start there, and then we'll talk about access.
So generally speaking, the rates of many issues are becoming pretty equal, on par. It used to be that we saw, at least in substance use, that the rates of addiction were higher in men, and unfortunately, women are doing a very good job of catching up.
Equality.
Said slightly in jest. So I think the differences really become more important when you think about whether people seek help. And we do see that it is more likely for women generally to seek help than it is men.
Yeah.
I would also say that studying mental health by gender is fraught with complications because it used to be the case that many of the issues we saw presented were attributed to women and hysteria. And issues like that. And so they're based in gender roles. But generally speaking, what we do know is that the treatments work equally well. And that everyone can benefit from treatment. Women seek help more, but men need it just as much.
Oh, yeah. Yes, we see that in the jails. We see that show up in our crime statistics.
Sure. Can I just mention one thing about the jails? Because I think your point was just so important. It goes back to your comment about evidence-based. Yes, I think I agree with you that unfortunately the criminal justice system has become the de facto treatment system. Having said that, I do think it's important to think about what treatment means and what is offered in the context of incarceration, because it's not necessarily evidence-based, and particularly in the case of substance use, which is a major driver of incarceration in the United States, there is very little access to any type of compassionate care that optimizes that person in a way that will have them successfully reenter the community. And arguably, I would also say there are a lot of people incarcerated that probably shouldn't be because of a drug-related crime. So I think that's important. I don't no disagreement with what you're saying. I just think treatment is not all treatment is equal, and not all things called treatment are treatment.
I'm going to switch it up a little bit. Very good point. There were a number of predictions in this time 2 years ago, April 2020, about the things that will stay and that will remain forever and have always changed because of COVID. Some of them were so broad they had to be right, like the year will be different next year. One of those predictions that was true is the acceleration of the telemedicine. And I think about access in some businesses, and mine, for construction, you have to show up. And what you've worked on with our school districts is we need someone to just show up. We can't rely on a good cell phone signal. We can't rely on any other access. But telemedicine has changed. It has become adopted. I think McKinsey said it was like years and days. It was like 10 years and 3 days was about how they've analyzed that. It's different for adults and children. And so I've got a couple of anecdotes here, and then I'll shut up for a second. My wife is a school teacher. She's involved at a high school, at kindergarten through high school, and for years there were always providers that would come and leave their business cards at the office. If there's anybody that needs any help, I'm a new counselor, I'm a new therapist, would sure like to help your kids, sure like to help some parents. Now they're not at the office, they're not at the school, and they're not available because they're so busy. And so now access what it meant for access is changing again. Two of my children come from hard places. They've been adopted. We adopted them out of foster care. I'm very proud of them. And one of them is in counseling, and the only counseling we could find was during school on Zoom. And so that's a big chunk. And then my wife and I we call it parenting coaching, but it's counseling. Also provided by a group that's dedicated towards parents of sort of post-adoptive counseling. It's all on Zoom. I have no idea where our counselor is. So telemedicine, how's it working? Why did it not get adopted sooner? And what's working? And what do we need more of or less of? Is it policy? Just talk amongst yourselves, ladies.
How many of you have ever waited for a really long time in the doctor's office?
This guy.
Yeah. And I am a doctor, so you'd think that I wouldn't have to do that, but I do. Yeah, so I think one of the best things about telehealth is if it doesn't eliminate your wait, it eliminates your wait in a kind of miserable environment, which no matter how beautiful your office is, which a lot of us, this space is very beautiful, but it's also very cold. So I wouldn't necessarily want to sit here for an hour waiting for somebody. So it allows the person to be in their own milieu. So like Andrew was talking about, like Zoom during school. So say you had to have an appointment during the school day, that would be you getting picked up an hour early by your parent who had to take off of work, taking them to the location, being there early because you probably have paperwork to fill out, then waiting, then having the actual visit, and then you have the travel back. So telehealth eliminates all of those transitions of care and all the things that could happen in between times, which would prevent you from actually getting that care. So say, the car broke down, you don't make the appointment, but now all you have to do is have either a cell phone, a landline, a computer. We can basically make anything work to get you the care that you need. And it's specifically helpful for my palliative care population where...
Would you talk about that for a minute? Because I can't say it. I can't even say it, let alone know what it is.
Palliative care.
Thank you.
So it's care for... oftentimes care for people at the end of life. So it's helping people with very serious illness feel better. So we're not all about like what your labs look like or what your last CT scan showed. We're all about how are you feeling and how can we help you feel better. So for our patients, they're often very sick. So getting into the clinic for these patients can be like a day prep before and then like a 2-day rest after because it's so taxing for them to take the energy. And for my patients and what I want for them, I want them to spend the days that they have remaining doing things they want to do, which even though I'm delightful and I'm sure the hour with me was amazing, probably didn't compensate for the 3 days that they lost in energy. So being able to provide that care to these patients in the home has been a game changer for me and a game changer for them and really for the families that has to invest so much in getting patients.
Now, are you having to do stuff differently now? I imagine, does it hurt here? And does it hurt here? How do you...
Right, so, people do talk about the physical exam and there's been a lot of data showing doctors just aren't that great at the physical exam and that, even though we think we need to, check every nook and cranny, that we actually, there's no consistency between two providers. So we could both walk in, do the same thing, and we'd both come out with something different. So really, again, with palliative care specifically, it's all about how the patient is feeling. So no matter where your pain is, I can help you feel better. And if you're short of breath, I can hear it on the phone. If you're anxious, I can hear it. So there's really not much we can't get telephonically, and then if there is, we can always transition over to in-person or get a lab at a community.
What about mental health? Yeah.
So Be Well Texas that I mentioned earlier, that's a shameless plug, but the reason I'm mentioning it in this context.
Be Well Texas.
Be Well Texas. The reason I'm mentioning that is it is a 24/7 staffed mental health and substance use treatment program. It's the only one in Texas that is publicly funded through federal dollars on behalf of the Texas Health and Human Services Commission. We've learned a lot from that, but one of the things that's been really wonderful that while my husband may not have enjoyed his urologic exam via Zoom, it has been a real gift for that was a joke, by the way.
Yeah, those are
happy with me. It was very stressful and traumatic for him. But what's important, and one of the things that we're seeing with telemedicine that I think is going to stick for mental health, is that it really does create the opportunity. The jury is still out on whether it will achieve this, but it creates the opportunity for access in a different way with a lot of caveats.
Okay.
You mentioned if you have a phone, if you have a smartphone, and if you have a computer. So that's the first challenge, is what does access mean? And access probably means more than whether that person has it. It means how do we create those access points,
Okay.
like a school? How do we create and make it easy so that people can avail themselves of these services? So that's one thing I think is really important when we're talking about it. It also helps if the providers are present and focused in their work to overcome some of the stigma and shame, both from the individual, from their family, or from society, quite frankly, including the systems that provide care. To allow that person to receive confidential care in the privacy of their home, where they might quite honestly feel safer. They might not always feel safer, and we need to understand that, because guess what? Everybody doesn't have a 3-bedroom house with 2 bathrooms and an office at the front where they can go in and have that. So I would imagine in children's mental health, ensuring the privacy so that those young people feel safe enough to share in a way that doesn't have adverse consequences. And then the one other thing is, I think our systems of care really need to reflect on whether or not we make it easy to receive care beyond just the access point and whether you have a mobile phone. Those waits are because of front-loaded appointment systems designed to make it easier. So we are not always patient-centric. What's nice about telehealth is it allows our healthcare providers and our systems to maybe, just maybe, create systems that are much more patient and human-centric to make it easier. I don't go to the doctor a lot because I work a lot, and I know that. But many people don't have the privilege that I have, and it's another piece of the puzzle. So telemedicine is an opportunity, but I believe it's still an experiment. Can we truly realize the opportunity?
Very good.
Can I just
Yes,
add something
please.
to that? So part of that is, and, some telemedicine appointments are great. Like, I need a prescription refilled. Can I just get on the iPhone for 5 minutes with my doctor and not have to take off work and all that kind of stuff? Mm-hmm. But for a lot of constituents that I represent, it's not just about having the device to log in, but there are still parts of Bexar County, which is a large urban county. So can you even imagine the rural counties in the middle of Texas? There's lots of areas that still don't even have the infrastructure for high-speed internet access. And then even parts that do have that, of course, you have to pay a monthly bill. And so access comes in a lot of different levels.
Yeah.
And again, as an elected official at the county, that's something that we're looking into to tap into. And it's something that we have been talking, as my background's in education, about the digital divide. But of course, the pandemic has now made people recognize it's not something we can continue to ignore.
That's very good. Thank you. Is that something, there's a couple of services that have come up where one is counseling via text, which fascinates me.
It's evidence-based.
Is it evidence-based? So I'm signing up because I'm texting all the time, and I could get a little help during stressful things like this. So that's one. That's interesting. What about for kids? What are you seeing? So your kids are coming to you. The hospital has a nurse line where they say, before you come, like call me, and I'll tell you that your kid's 98-degree fever. Is it a fever? Take a deep breath. But if they're bleeding a lot, you should come. So what's going on with what you're seeing at Clarity, telemedicine, and then I also want to talk about telepharmacy, which you mentioned.
There's a lot to unpack in that. So
We still have plenty of minutes.
I actually want to go back to one of your first points.
Yes,
is
ma'am.
why didn't we do this earlier? Why didn't we launch telehealth earlier?
Yeah.
And I saw two things. One, on the behavioral health side, psychologists and therapists have really argued against telehealth for years. There, at least in my experience, that you don't get the same connection with a child, with the family over an internet connection that you do when they're in the room. So, we had discussions either pre-pandemic of do we expand our telehealth services, and there was a lot of just pushback. The pandemic forced us to rip off that Band-Aid, that we had to do it if we wanted to still connect with people. And so that kind of forced us to get over some of our own institutional barriers to that. The other thing is payment. There were some emergency declarations by the governor early on that allowed for telehealth billing that had previously not been allowed.
So that's important. I want to make sure that our audience is getting that. There was a change in policy
Correct.
that allowed payments to come through even though you haven't seen the patient in your office.
Correct.
And that had been a prior entry and that barrier to entry could have been from the practitioner saying, no, it doesn't matter. We need to see each other. We don't want quacks taking them over the phone. We're the real deal. Come see me in the office. Okay.
So that definitely, I think, was part of the reason why I know we didn't launch it in full scale, and probably some other providers didn't as well. That door is now wide open, and that has been a permanent policy change at this point. So that barrier is no longer there. With kids specifically, I think it's always going to be part of our toolbox, but it's not our only tool.
Okay.
I think it's great for some kids and some families. It's not great for the little child.
Okay.
For a 4, 5, 6, 7, 8-ish, maybe 9-ish, it's just not the same connect. It really isn't the same connection. And if you've got a kid that has any kind of developmental or processing issues, it's very hard to make that connection over Zoom. So, there's going to be a certain population that we're not going to use it with, but it's also opened a door to a population we probably wouldn't have seen. So it's a great tool.
So
to
there's
have
our
in
access.
our
The whole
toolbox.
landscape is changing.
But the thing about access, which I think gets confused a lot in talking points, is people point to telehealth as solving the capacity issue. You still have the same number of appointments. If I've got 4 providers, I can do 100 sessions a week. That could be in person or that can be via telehealth. So unless we develop the workforce, it doesn't really shift our capacity to do more. It's just the format that we're doing it in.
Interesting. So go ahead.
That's where the texting comes in, if you're interested.
Yeah, because that's
I wouldn't
across
recommend
state
it as
lines.
the only alternative, but.
Yeah, well, okay.
But so originally we had talked about part of this being technology, and I'll just super quickly because I don't want to monopolize the time, but one of the things is understanding and doing the research to understand whether we can extend that one-on-one human interaction or a group session in a way that allows us to serve more people with the same capacity of providers. So when you mention texting, there are tools that have now been developed as adjunctive work, add-ons, to be able to provide people to check in. We have
Follow-up type.
Yeah, so we have a small business project that we're testing right now, and once someone is discharged from a treatment setting, what our app does is it uses artificial intelligence and machine learning to get real-time data from their mobile phone and their experience to provide them with coaching. That's the type of interaction that I'm sure your clinicians would love to be able to do, but they're busy treating the next 100 folks and the next 100 folks. So when they talk about the intersection of technology and mental health, that's the piece that we're trying to do, is how do we stretch? How do we do more with the same amount of people in the workforce?
Heart rate variability,
Yep.
biometrics,
Yep.
items like that. So pharmacy, e-pharmacy, there's a website for hims and for hers. I think that's right. You can get hair loss medicine and I think antidepressants. There's a few and a couple of other more intimate types of medicines. That has happened because of changes in policy. And so we're hearing changes in policy allowed billing. There were changes in policy that allowed Medicare across state lines, teledoc. We've experimented with a lot of policies. Some have worked, some have not worked. One of the policies that changed in Texas was you were allowed to buy alcohol to go. And alcohol was one of the essential services. which when it started, there was a lot of celebration, and then there was a lot of jokes about how the children's teacher was fired for drinking on the job, and of course it was the parent, because that was the joke. If my kid's teacher's horrible, they drink on the job, and I'm their teacher because we're all home together. Those jokes and that change of policy, we're seeing perhaps around the community, we're seeing the negative side effects. So let's talk about policies a little bit. Some are working, some are still temporary. What needs to be permanent? What didn't work? And as part of those policies, I'm just going to load the table up here. Communication policies. I know from the public side, we tried all kinds of stuff. Amber Alert style, texts, all kinds of different. So what kind of policies worked to reach people, to communicate to people, that made stuff worse? Who wants to go first? And then I think we can open it up to questions here. This is a pretty wild bunch, so I don't know if I trust it, but we'll try.
I mean, just speaking to access and specific to kids, the pre-pandemic process for staying on Medicaid is very cumbersome. It involves, I believe it's a monthly check-in to get recertified, and you have to sign back up, and if you don't do it, you lose it. They changed during the pandemic to allow for, and I forget the exact details, a longer enrollment period. So it didn't force the families to have to go through this process. Because we see kids a lot that have been on Medicaid and they've rolled off, and you have to get them back connected to the Medicaid office, and it's just a very cumbersome bureaucratic
That much more
process.
stress to
Yeah.
bring a kid who's throwing violent tantrums. to the
Exactly.
office.
And so that would be a great policy to keep,
Okay.
that we could keep kids enrolled in Medicaid with certain caveats, and but it's another barrier, and it's another hoop that our families have to jump through to access care that they need for
Yeah.
kids that do qualify.
Yeah, very good.
If you go first. I have so many, so.
Yeah.
Telehealth payments need to stay. So again, as she was alluding to, before you could do some telehealth, but it was reimbursed at a much lower rate because it was just like, oh, you're probably not doing much. But you are, and you're providing, actual health care. So that needs to stay, and that respect for how that care is delivered. Because again, it's the physician providing the care to the patient, or the other provider providing the care to the patient, and that doesn't necessarily have to be with me touching somebody to be able to help them. So that definitely needs to stay.
Very good.
Margaritas to go definitely needs to stay.
Yeah. Yeah. Okay. Good. Allison votes yes.
That's for my resiliency. I'll let her pathologize that later. But there were also some good research positives that came through the pandemic, which was things got through faster. So in medicine, it can be years before we get an answer to a question that we needed yesterday. And so with COVID, everybody understood we don't have that kind of time. We can't wait, the 3 years for that full study to happen and make sure like absolutely every T was crossed and I was dotted. We need to know now. So having that speed of importance continue is going to be something that I hope the medical community will maintain moving forward.
I'd like to hear, Commissioner, if you have something, and then I've got a new question. I know you're dying to answer, but do you have anything you'd like to?
Nothing pressing.
Okay. So one thing I do want to talk about, because then I want to open it up to questions if we have any, both from around the galaxy and here in our very own room, is we haven't talked about prescriptions for fitness and nutrition. We found during COVID that vitamin D deficiency may play a significant role in your health, and that vitamin D deficiency can come from your pigmentation and where you live in the world, or because of it's not fat soluble. I think that means that if you've got a lot of fat, the vitamin D doesn't soak in. Hopefully I'm not making that up. We also have a lot of issues with comorbidities. We've learned a lot about obesity, diabetes, something that we deal with significantly here. And those roles on the effects on mental health of our personal health. Are you seeing encouragement, any discussions? Should this be a part of our topic, or someone else has got that handled? What are you seeing with nutrition and diets and exercise and get outside and maybe lose some weight?
So again, my background's in education. I also worked in public health. So something that I had always been talking about and doing research on are social determinants of health, access to education.
You said social determinants
Social
of health.
determinants of health and access to education. And part of that is preventative health. And preventative health doesn't just mean go get your mammogram. It's also about eating right and exercising and getting fresh air and sunlight. So one of the things I'm really proud about is that Bexar County, Dr. Potter, I think your opening statement, you mentioned something about the public health failure. That is also true here locally.
Yeah.
And because of that, you can't wait till middle of a pandemic to then go build relationships with the hardest hurt communities, which are often people of color and impoverished areas.
Yeah.
And that's really what was trying to be done, at least here locally. So one of the things that we recognize at Bexar County is that the local public health authority wasn't stepping up, wasn't doing its job. So we just announced 2 months ago that we committed $60 million to work with our hospital. And I'm happy to say there's someone here, you can raise your hand. There's someone here from UHS. And so UHS is University Health System, which is the Bexar County Hospital District. And we have just allocated land and $60 million in my precinct on the south side to build a public health division. So not just focused on the people who have the easiest access in San Antonio, but all of Bexar County.
Good.
And part of that is about community education. So whether we're partnering with community organizations or churches to teach healthy and cooking classes, just very basic things. Because we were, in Bexar County, we have a really large percentage of obesity, diabetes, amputations, all that affects.
We call those comorbidities. Well, I'm learning. I know what that is now.
Everyone knows what
Yeah.
that word means
Yeah.
because of the pandemic, and they were like, oh, underlying health issues. What? That means you're going to get COVID worse? Duh.
Yeah.
And so these are things that I think educators and people in public health had already been talking about. And so now these are common words that people know. So now we really need to attack it and fight it. So the things that we had already been talking about pre-pandemic, because of the things that everyone knows now,
Yeah.
it's something that people talk openly about, and they're no longer able to be silenced about it. And so we have to push dollars towards that.
You're dying to say something, and then we've got some preguntas.
I think I was back at policy.
Yes, ma'am.
There are medications to treat opioid use disorder, and I just have to remind everyone there are more people that have died in the United States from opioid use disorder than at the height of the AIDS epidemic. Wow. More die than motor vehicle accidents, more than in the Vietnam War, and so the context of death is really striking. 105,000 people we estimate will die in this year from drug-related overdose death. Wow. So my point in mentioning that was really super simply that prior to the changes in policy, we were not allowed to prescribe a life-saving evidence-based treatment using telehealth, and that was for a medication called buprenorphine. We can now meet someone where they're at and prescribe this medication that will cut the risk of an overdose death in half. If that is eliminated, that is a huge barrier to being able to mitigate the opioid crisis and the associated consequences, and it will hurt the people with the least amount of privilege when we do that. So I just wanted to mention that.
Do we currently have
as
an
a policy.
emergency authorization that has maybe an expiration date to it?
Yeah, it's been renewed a few times now. It also allows people to have a 28-day take-home of methadone. Right now, if you have an opioid use disorder and you're prescribed methadone, you usually have to go to a clinic every day. Imagine going every day at 6 a.m. to a program rather than having that access made just like you could get any other prescription. And so it's complicated, but I think access to treatments that save lives is essential, and the evidence suggests there's been no unintended negative consequences from having these policies loosened. So I just wanted to mention
feel
that.
enormously blessed to have had you four all to myself. Now I need to open it up to questions. Yes, sir, and I think we may have a microphone, and then I'll read your beautiful handwriting here, if we could. Oh, well, that's very generous of you. We had a question here for the gentleman.
You just mentioned the opioid crisis and the fact that there is a medication that's available that could help people. So who is it that's benefiting from these people not being able to get the medication? And why would it be that if it's available and there's something that's already something that is in our possession and could be used to take care of the crisis, why is it something that keeps on having to be legislated why are there policies are there policies keeping this from being in place? What drug company is trying to keep this from being something that's accessible? I mean, it has to be somebody that's benefiting from people not being able to have this treatment.
If there's a clear answer, hit it. Go ahead.
So it turns out in this particular case, it's not the pharmaceutical companies. In this, I would not say, except if we roll it way back. I think this is a failure of science to translate into policy. And I began my comments with this greatest public health failure of our time, and I still hold that, in part because with COVID, we did not know what to do, and we did our best. With the opioid use crisis and with opioid use disorder, we have 3 FDA-approved medications that will reduce the risk of overdose deaths. We have known about those medications for decades. It was a failure to implement the access points for that. Some of these medications are, there's a way that we deliver them, for example, with methadone and with buprenorphine. It has taken us 20 years to elevate the conversation around access. My personal perspective on that is that that comes from the stigma around people who use drugs and the discomfort that we have as a culture with drug use. As a result of that, people are put into alleys and prison and jails rather than providing them the care that they need. And I completely agree with you. I sense your frustration, I think, and you feel emotional when you're talking about this. I share that with you. It is a travesty. I will say that the monies that have come recently from the federal government, both from the prior administration and the current administration, which is why we need to continue to have federal funding for healthcare, including mental health and substance use disorder, which would be a really great policy, is going to do that. So in Texas right now, anyone in Texas has access to no-cost buprenorphine. We need to make sure that our providers are prescribing it, and that's part of what we do. So if you'd like more information, I'm happy to talk to you after this, but I completely agree with you, and thank you for that question.
So I shouldn't offer to sell some in the parking lot after the, no, I'm just kidding.
I personally wouldn't have a problem with that.
Okay, she'd be good with it. I have a couple of excellent questions here, and because each of you that were able to make it, hopefully just have some time afterwards. We have about 5 minutes left. I have a question here that is, the pandemic exacerbated and highlighted a growing trend in social isolation and loneliness. I would think this would happen in end of life as well. Are there evidence-based practices for addressing isolation and loneliness? 3 seconds or more. Are you seeing evidence-based?
Yeah, yes, there are. I mean, I think we need to help people get out of social isolation. If it forms and manifests in the form of social anxiety,
Okay.
There are really great interventions for adolescents. Exposure therapy is an example.
We just need to raise our hand
Yeah.
and start asking around. What about, is mental health a social issue or a policy issue? Should we destigmatize mental health, or should policy enforce mental health access and support? That's kind of an either or, and I know what you're all going to say.
Well, that's like saying, is healthcare a social policy or a public? It's both. It's both.
Excellent.
It's mental health is health, and it's got, the policy has to back up the interventions.
Question for Dr. Wiesenthal. Does the Center for the Intrepid use telehealth with physical therapy and teaching how to use prosthetic devices?
Great question. So that was one of the bigger challenges with the pandemic, was because at the Center for the Intrepid, we have the prosthetics fabrication on site. So people are used to coming, getting their prosthetic, getting it adjusted real time while they're doing their physical therapy. So in some ways, no. It's just kind of like a surgeon can't operate. Well, you can operate with a robot remotely, but still at some point, somebody's touching the patient. So there definitely are limitations to the telehealth. We have been able to operationalize physical therapy by telehealth with the same benefits we talked about before. But with our prosthetics, we really do need that hands-on touch. And that's one of the incredible things about the Center for the Intrepid, is that they're able to do that all in one space. So they do physical therapy on the 3rd floor, they walk down to the 2nd floor, and the prosthetists are able to adjust their prosthesis real time and then get them right back up to physical therapy to see if that's what's going to work for them when they walk out the door.
So I'm going to end, I think we're out of time. Is that about right? I'm going to end with a point here. Go
right ahead.
But wrap it up? Okay, go right ahead. What I'm hearing is that we're all now in this room and online, we're aware of what's worked, what our family members, what our neighbors and some of us are going through. And the answer is we now need to spread the word. And we can have effects on policy, we can have effects on funding, but we can also have an effect on our family members and our neighbors by saying, how are you feeling? What are you feeling? And being the community that I believe is essential, according to the title here. And so I think we've all been armed now with some very important things about what comes today and what comes tomorrow. And I just consider it an enormous privilege to have shared the stage with you ladies. If you would please join me in a round of applause, and then we'll wrap it up.